session, but maybe there is. It's diet, because it's come up in everyone's talk and certainly will come up next. Dr. Wieland is our expert, certainly at our center on the management of MASH, and one of my colleagues and another transplant hepatologist here. So Dr. Wieland, thank you for this talk.
All right, wonderful. I'm excited to be here for another year. This is a wonderful conference. And I will dive right in. Thank the sponsors for inviting me. Let's see. I guess I'll push that. All right, wonderful. So goals today. So I've been asked to frame talking about metabolic liver disease or metabolic dysfunction associated steatotic liver disease in the setting of a case, which actually was pretty fun for me to kind of take some of these patients that we followed over the years and have showed good response and kind of show off what we've been able to do and help reverse this disease. So we'll talk a little bit about steatotic liver disease in general, but I'm really going to focus on MASLD today. And we'll go through tools. I'm going to weave in a lot about liver biopsy, and then also talk about the key non-invasive tests that we use to follow this disease. And then we'll talk about management and really highlighting the new pharmacotherapies and how we can help modify this disease. All right, so let's start the case. So this was a 42-year-old that I met a couple years ago now, and she'd had a history of chronically elevated AST and ALT for many years, over 10 plus years. Her liver tests varied throughout her kind of adult life. Her ALT had been 60 up to 100 or higher, her AST 50 to 80. Really pretty healthy lady overall. Her BMI did run around 30, and she carried it in a central pattern, and she had hypothyroidism, but otherwise very healthy. She was followed by her local team for many years, and they'd done the appropriate workup and updated things in early 2024. They did an ultrasound. It showed steatosis, but otherwise was normal. The blood work was very complete. Serologic workup was done on her that I'm sure you guys are familiar with, all the blood that we do. And everything was negative, although she did have a positive ANA. And they'd really been working with her on weight loss, and they'd even used pharmacotherapy that was available at the time. But her labs really didn't improve, and they weren't making a ton of progress. And so what's the next step? What do you do in a patient like this? Thinking what you might be doing. So I wanted to pause here and talk about the role for liver biopsy. So there's a couple major reasons that I really highlight that a biopsy is still important. One of the big things is confirming the diagnosis. So if there's something in the workup or something where you're doubting the diagnosis, a biopsy is still very appropriate. If, the ceruloplasmin is low and all of that, as we just went over, because you want to think about other things. But, overall, there's a lot of MASLD out there. So suspecting MASLD in this patient, who obviously was very high, but the fact she wasn't responding and this positive ANA in a young woman, thinking about a biopsy, I think is very appropriate. The other reason to have a biopsy is if you're having conflicting non-invasive testing, trying to understand the amount of fibrosis. So fibrosis, which we'll go over later, is obviously the really important factor when we're looking at the spectrum of MASLD, because once somebody starts to develop at-risk fibrosis, those are the ones that we worry about future liver problems. Obviously the whole spectrum of MASLD, they have health risk, but fibrosis from a liver standpoint is where we really start to get worried. Whether or not you need a biopsy to decide about initiating pharmacotherapy targeted at MASH, the short answer there is no. You don't need a biopsy to decide on pharmacotherapy, but if you feel confident in your diagnosis with your non-invasive testing and your serologic workup, you don't need it. So, and the guidelines pretty clearly state that. But, if you're not sure of the diagnosis, or if you're getting conflicting results, definitely biopsy still important. All right, so this lady had a biopsy. I really set that up. So this was her initial biopsy. I apologize. I just took this from the path report. First of all, I feel like the pathologist is yelling at us, and so that's one issue here. So this biopsy was back in 2024, so a couple years ago now. So I want you guys to kind of look at that. I highlighted a couple of the things that, were a little clear. There is steatosis, so there is fat on this biopsy. And they said she had cirrhosis. So that's scary, right? Lots of other words here. There's cells. They say there's not some stuff, but so just kind of look at that and think about it. All right, so what do we do with this biopsy? So it's done for appropriate reasons. We think this is hepatic steatosis. So do we just still focus on lifestyle? Are we just going to have her lose weight? Is she a candidate for pharmacotherapy targeted MASH? Should we do clinical trials? She has cirrhosis. Do we need the latest and greatest that's out there? Does she need a liver transplant? When the patient sees cirrhosis, they're like, I need a new liver. You got to swap this out. They're terrified. Does she have more? Is there more testing we should do? Is there something else that we need to clarify what we're going to do? Do we need to phone a friend? I think that's always a favorite of mine. I feel like I went into liver disease because I can't make any decision on my own. I'm always looking for others to help me. All right, so let's step back and think about the spectrum of mast load again. So normal liver, nice and pink and happy. Once things start to progress, we see the white. White is bad. That's the fat starting to accumulate. But just having the fat in the liver, in general, people usually do well from liver-related outcomes. The next box there is MASH. So MASH is the concerning part of the spectrum where you get inflammation, start to lead to scarring, fibrosis, and that's where you can get cirrhosis. So let's step back and think about, how do we know they actually have MASH? What is MASH? MASH is actually, at the heart of it, a histologic diagnosis. And so from a pathology standpoint, there's 3 different key features you should see on the biopsy that tell you they have MASH. Now, there's actually a lot of conflicting things out there from the pathology world as far as what exactly a pathologist is going to call, but they really should tell you how much steatosis. And then they should talk about ballooning. Ballooning is actually the apoptosis, the dying of the cell. So that's where you get these swollen, that little guy in the middle is a swollen, sad hepatocyte that's exploding. So that's bad. And then the third thing you should see is this inflammation. And it's just kind of a general mixed inflammatory infiltrate. So in general, in the pathology world, blue is bad. So you see there, you get this score. It should add up to 8, depending on how much you get. So if you're to really call it MASH, you should have each of those characteristics: fat, inflammation, and ballooning. And that could put you at a 3. So 3 to 4 is kind of borderline MASH. And if you're over 5, you're definite MASH. Now, the fibrosis. So this is the trichrome stain, one of my favorites. I think it's very colorful, although the color can be bad because, again, blue is bad. So the fibrosis, when we talk about MASLD, the stage 1 can either be this perisinusoidal, where you get these little blue outlining the hepatocytes out in the lobulum. We call that chicken wire. You can kind of see that looks like little chicken wire. I don't know if anybody's seen chicken wire, but that's what it looks like. The second is this periportal fibrosis. And so that's around the portal triad. And you can see there's this expansion and increased blue. When you have both of those, that's going to get you a stage 2. And stage 2 is really, again, when we start to see liver-related issues, and that's where we're much more worried. And then stage 3 is these bridges, these kind of bands that start forming. And those are what forms your circles. And these well-formed circles or nodularity is what we're going to call cirrhosis. All right, so back to the biopsy. So again, sorry they're yelling at you. So does this patient have MASH? From this information, yes or no? I have no idea. I cannot tell from this report that was out there if this patient actually has MASH or not. So phone a friend was the answer. So first thing we often do, we are very lucky here to have all these great resources. So I do not take it for granted that being able to actually look at this biopsy and have a pathologist that we can clinically correlate and actually know what this truly is very important. And we are blessed that we can work with our pathologists and have a meeting where we have dedicated time to review this. So first of all, they're not yelling at us, and they're very pleasant. They actually thank us for letting them do extra work and review this for us. So you can see there that they clearly tell us this is steatohepatitis. There's fat causing inflammation. That's what driving this. They do not see features of autoimmune hepatitis, which was in the background of what we were worried about. And they tell us the NAFLD activity score, 5 of 8. So this is definite MASH. And the other key thing, it might seem shocking, but she actually does not have cirrhosis. They just said cirrhosis in bold. But actually, when we look at it, she's much more characterized better as a stage 3. So again, you would think that would be a clear thing, like cirrhosis, not cirrhosis, but there's a lot of subtleties to that you really have to look at with your pathologist. So that is really important. So this really changes the paradigm for this lady. So I want to step back and talk about other tools in identifying MASH with fibrosis, because that's really important in kind of the long-term goals for this patient. So the liver stiffness measurement tools. So the first one there, vibration-controlled transient elastography, VCTE. That's really the workhorse as we're following these patients, also initially for diagnosis of the at-risk MASH, and then for following them on treatment. So it really is a very important player and has really become a key part of our management of these patients. FibroScan is the most common system available for VCTE, and it tends to be our go-to just because if you have it available, it's nice because you actually get a full report that I'll show you where you can actually validate that you got a good scan, and it just is a nice way to follow these patients, if you're getting a good correlate. And in general, in screening for mast cell and trying to find these at-risk fibrotic patients, if you have a low score, you can actually be very confident if it's a good study that they're not in the at-risk category, and you don't have to be as concerned about the liver. You obviously need to trend things, but it really is very good at excluding these at-risk, and a definitely advanced fibrosis it can help you exclude. MRE, I'm not going to go into too much. It's a nice tool that we have if we're having challenges with not getting a good quality scan. So we use that here in certain cases, but in general, the BCTE, if you're getting a good one, is a great tool to have. You can see there just point of care in the office. And this is just kind of showing you those waves. So, the FibroScan, you guys have probably seen it. Basically, you have it's very similar to ultrasound, and you find that nice shear wave, and the speed of the wave or vibration in the liver correlates with density. And so you get that nice wave there that you can follow over time. So we did a FibroScan in this lady, and you can see there the FibroScan actually correlated quite well with her biopsy and actually made sense, right? So now we know she's at stage 3. And so actually 13.4 really fits nicely into that range, that 10 to 14 about, but there's a lot of wiggle room in here for these. And so seeing that, so now we actually have a good baseline, and we actually are like, okay, we know what's going on for our lady. So now what do we think about our options? What are we going to do? A lot more hope for the future for her. So I would say we did these already. She's really optimized from her lifestyle intervention. She's doing her best. She's really, really doing all the diet and all those things, still not making progress on her metabolic management. We've done more testing. We've validated our biopsy. We know what we're trying to treat. I don't think this lady needs clinical trials. We have good things approved and available that we really need to be aggressive about helping as tools for her. And right now we're trying to avoid transplant. Don't tell my transplant team, but in general, I'm doing my best to have people not need a liver transplant. So we're moving on to the pharmacotherapy. All right, so medical treatment options for pharmacotherapy for at-risk MASH. So this is a very exciting area. For many, many years, we were doing trials and nothing worked out. But it was the fall of 2023, so a couple of years ago now. This is when the Maestro trial came out, and it was like the culmination of so much work out there. So this is when resmetirom, which is a pill, it's a beta thyroid receptor agonist, and so it's specific to the liver, and so basically revs up how thyroid works in the liver and really does a great job clearing out the steatosis. So so this was a 52-week, so a year trial, almost 1,000 participants, and these were all biopsy proven with a NAFLD activity score, and you guys all know what that is now, of greater than 4. So really pretty confident of active MASH. And they were most of these were stage 2 to 3, so really at-risk MASH. And they were on placebo versus 2 different dosings of resmetirom. And you can see there the primary outcomes with MASH. There's 2 major ones that the FDA mandated that medications needed to meet. One was resolving MASH. And so actually we're going from MASH to no MASH, or actually showing that you reversed fibrosis. And so going down 1 stage. And this met both. This is the first thing to ever do that. You can see their placebo was really in that not too exciting range, maybe up to around 10%. But in the treatment arms, they had, in that range of 20 to 30% resolving MASH and actually reversing fibrosis. And I think this idea of reversing fibrosis, I still have to convince people we can do it. And we can actually reverse pretty significant fibrosis, which I will show you. This is just trying to point out this and highlight that it was across the whole spectrum of more people stayed stable and definitely fewer got worse and some improved. So really across the spectrum, this really had an impact. And overall, one of the really nice things about resmetirom, and having used this for a while now, it's overall very well tolerated. Of meds we give to people, it's something that people do quite well with. I will say it is pretty common, or not uncommon, to have some GI issues. So you can see there in the study, it was about 30% would have diarrhea or nausea. It's probably something to do with the mechanisms of how the thyroid and the balance of the body, but most of the people, even if they have some issues, it really abates over a few weeks, and most people tolerate it quite well. So with all this data, resmetirom, Rezdiffra became the first FDA-approved medication for at-risk MASH in spring of 2020. And so right as we're seeing this lady who's been working so hard for years, we have this new medication available. So very exciting. And she really falls in the sweet spot here. This is a really nice decision-making tool for at-risk MASH that came out from the ASLD. So I definitely encourage you guys. These graphics are nice and colorful. You can see there, she really falls into this nice sweet spot of recommending treatment. And in general, again, highlighting, yes, I showed you a lot of biopsies, but you don't need a biopsy. If you have the workup and you really feel confident that this is MASLed, which it usually is, it's usually not Wilson's, despite what John Rice will try to tell you. But if they have MASLed and you feel confident they're in this at-risk group, using these meds is very appropriate. So as you follow them on treatment, so you initiate treatment and then monitor them for safety, every few months. And this is, again, from that same publication from the ASLD. And in general, watching them with these non-invasive tests, we're not going to rebiopsy this lady like they did in the trial, right? And that's why having your non-invasive, like a good baseline that you're going to follow on treatment is really important. And you can see at a year, they recommend reassessing and improvement in liver tests, improvement in your VCTE, all of those. If that looks good, then you continue. If you're in kind of a gray zone, it's kind of a risk-benefit balance, but often continuing to see if it's just taking longer. If things are getting worse, then it's probably not what you need, and then you would probably stop. All right, so let's talk about our patient again. So we started on resmetirom in August of 2024. Unfortunately, this poor lady has no luck. So she actually got nausea and abdominal pain with it, which was pretty significant. So she paused it. We're like, okay, let's try again. Try it again. Unfortunately, when she tried it and then immediately started vomiting, she just had a very unusual, very atypical response. And then she also got a rash. So it seemed like it was actually almost a different mechanism for this poor lady. So unfortunately, we really couldn't keep her on the resmetirom. So now what do we do? It was the spring of 2025. This is when the Essence trial came out. So this was semaglutide, which I know you guys are all familiar with semaglutide and the whole spectrum of the GLP-1s. They're out there. They are a good therapy. They've got a lot of buzz. So semaglutide, this was the injectable form, so sub-Q injection, and it was the Wegovy, the dosing for the weight loss version of semaglutide. It was a 72-week trial. That's one thing to highlight. It was over a year, and they, again, biopsy-proven MASH, the NAFLD activity score greater than 4, stage 2 to 3 fibrosis, so that key group. And you can see there the placebo in this one, pretty strong placebo effect compared to the other. It was up to apparently you say semaglutide and they improve, I don't know. But you can see there, very impressive, 60% resolution of the inflammation, and then 36%, almost 40% improving fibrosis. And so then, thus, Wegovy, semaglutide, became the second FDA-approved therapy for at-risk MASH in August of 2025, almost a year ago now. So again, we got a nice algorithm. You can see there, again, she's in the sweet spot. And so the monitoring, very similar. You initiate safety, and then you're going to follow up. Note there, they do say 72 weeks, and that random 72 weeks comes from the study. We usually are going to follow them at close to a year. So you can see there. All right, so in summary, pharmacotherapy for at-risk MASH. So we've got 2 drugs now, resmetirom and semaglutide. The question of will you use them in combo, which to use first, what to try, it's variable, but in general, it hasn't been studied. So hopefully more data will come out on that. Usually you're going to do a patient-centered decision on which one to start. A lot of our patients are already on a GLP-1 or a different one. And I wouldn't stop a GLP-1 that's working for somebody to then switch to Wegovy. There's a lot of subtleties to that and there are other metabolic management. But in general, ultimately, a lot of patients would probably benefit from both. All right, so return to the case. So she started on Wegovy, December of 2025, lost 30 pounds. And so you can see there the arrows when she started, weight down, and her labs normalized, AST and ALT, which had been elevated for years, came down to the 20s, looked beautiful, and here are her follow-up FibroScans. So you can see there, we'd had another one in the interim, and she was still at 11.2, but actually was probably making progress on her own, although that one's not the best quality. The follow-up that we did after 6 months, you can look there, she's down to a 9.6, which is now a stage 2. And her steatosis score, I didn't go into too much for time, but the CAP score is a general idea of how much steatosis, and hers significantly dropped. And so lots of hope for the future. We'll keep following this. Now, quick side note here, what do we do for the cirrhotic? So if she had been cirrhotic, what would we do? Studies are ongoing. We got some going on here. If you can get them on a GLP-1, that is still a good option for their other metabolic concerns, but you have to watch for sarcopenia and a cirrhotic. You have to be very mindful of not causing muscle wasting. If they have portal hypertension, you probably do just need a transplant, but clinical trials are ongoing. I just want to do another real quick case presentation. So this was a lady that we followed for several years now. First met her in 2020. She met one of my endocrinology colleagues first, and she'd had a biopsy in 2013 that showed F3. We repeated a biopsy that actually showed she was cirrhotic, and I'll show you those pictures. So she was a clear F4. And so she got sent to our dual clinic, and the endocrinologist honestly did all the work. He really optimized her lifestyle, her GLP-1 therapy for her very challenging diabetes. And she ended up losing a significant amount of weight. She went from 200 down to 140. And she remained well compensated, and we repeated a liver biopsy. So this is her H&E. There's 2020 compared to 2026. You can see there the blue has melted away. The white has gone away, and the ballooning is also gone. So she went from very active MASH, I think she was a 6, down to no MASH. And this is what's really exciting. So her trichrome 2020, big, nice thick bands of fibrosis, and 2026. I think they still called it a stage 3 for that little piddly band she had, but I mean, that is a very impressive improvement. So she actually has her cirrhosis being reversed by therapies. So quick take home. So I do think it's really important to think about and find these at-risk patients, because as you've seen, we can reverse this. We can actually prevent needing a transplant. It is wonderful to have the resource of a great pathologist and a multi-D team. I'm very grateful for that. They do all the work for me. I really do think that our workhorse of the VCT is really important. Having a good baseline to follow these patients is critical. And the management, never forget the diet and lifestyles. It is a diet theme this morning, so make sure they're doing that, but adding in the pharmacotherapy and well-selected patients really can optimize them. And for cirrhosis, we do need more.
All right, that was great. That was a really great first session. Paul, John, Sean, Amanda, thank you for those great talks.